So it looks like we have a good number of teams in the room right now. So I just want to remind everyone to make sure you guys' microphones are off while the teams are presenting. And yeah, I think we're ready to get started for tonight's semifinals pitch competition. And I'll give it off to Ryan to introduce sort of what we're about and what the pitch competition is about.
Awesome. Sounds good. Thanks, Rohan. Yeah, good afternoon, everybody. Super excited for the pitch competition we've got going on this afternoon. So my name is Ryan Morrison. I'm the Biodesign and Innovation Chair at the SIR MSC. And this pitch competition is for the annual Biodesign competition. So the two teams that are selected from this pitch competition will be presenting at SIR 2022. And we'll give information on the date and time when that's finalized. Just wanted to quickly plug the application that we have open for the MSC committee. It's open right now, due April 30th at midnight. This is what it looks like if you go to the SIR webpage. I can put the link in the chat in a minute. To apply, you just click, you'd have to sign in with an account, click apply today. And the application for all the different committees are on this one application. The biodesign, I recorded a biodesign and innovation summary of all the projects that we've got going on. And that's in this YouTube video that you can find linked in the application. And then finally, I wanted to share with you guys, I secured a ton of different prizes for the biodesign and innovation competition. So not just hopefully not just the first and second place winners will also be getting prizes. First and second place will get their choice of prizes. And then after that, we'll see how many we can distribute to the runners up. So we secured things from like Amboss, USMLE, RX, Boards and Beyond, Physio, Med Bullets, Pass Tests, OnKing Med, and Osmosis. It's a couple hundreds of dollars worth of subscriptions, which is awesome. So I think we have team one coming up. I'm super excited to hear it. And all of these will be recorded so that the judges can take a look at your pitches at a later time if they're not online right now. Good luck, you guys.
Thank you, Ryan. And before we begin, I just want to let everyone know that I will be cutting you guys off at 7 minutes and giving everyone a 1-minute warning before their pitch is about to end. And all comments or questions will be relayed after tonight's pitch competition by the judges. So don't worry about getting any comments tonight. And yeah, so I'm ready to kick it off. It looks like Tia Forsman is on deck, and I'll give you sharing privileges right now, Tia. And so everyone else that's not presenting at the moment, please turn off your webcams just so that there's a good stream rate for the presenters.
Thanks, Rohan. Appreciate it.
No problem. All right. You should be able to share your screen now.
I am. Okay, can everyone see my screen? Oops, not sharing, I'm just presenting. All right, can we see this?
Yep.
Great. Okay, so I will be presenting with Nicole Kim, and we are team one. Okay, so thanks everyone for being here. We are team one for the SIR Biodesign competition, and we are presenting Drain Pal, which is a palliative patient companion. Before we talk about Drain Pal, we wanted to talk about Miss M and her biliary drain. Miss M is a patient who is a 57-year-old woman with a pancreatic cancer status post-Whipple with recurrent malignant biliary obstruction. Iyer became part of her story back in September when they placed a biliary drain for her. And this was followed by several exchanges and checks of said drain. Following this placement, she also had 8 ED visits related to abdominal pain, drain complications, and then 10 hospital readmissions. And we noticed in her course of care that she had a palliative care consult 2 months after her drain was placed in November. So as a team, we wanted to ask the questions, how could we improve Miss M's care and her quality of life?
So the situation that was faced by Ms. M is one experienced by too many patients with chronic or life-limiting illnesses with drains. These patients face challenges including confusions regarding care for their drains, frequently insufficient discussion surrounding their goals of care, and limited opportunities to check in with their providers outside of interval drain exchanges, all of which conglomerate to create the potential for increased health complications and many preventable ED visits. It's actually been demonstrated that drain issues are the most common cause of readmission after IR procedures, and that it identifies a subset of patients at high risk for early mortality. Poor patient outcome is not the only concern, though, that arises with high rates of readmission. When ED visits become highly frequent, they become a source of increased patient distress and can be further detrimental to their well-being. They furthermore increase physician workload and augment the burden of healthcare systems at large, compounding costs and demand for staffing and labor. Others have attempted to approach this issue by either increasing education of patients and families before they leave the hospital or providing patients with home care liaisons or community-based catheter clinics. But these interventions are significantly limited by the sheer amount of resources required to implement them at a scale that would be beneficial to patients.
So based off of all those problems that Nicole just described, our team wanted to develop something that would help Miss M and other patients like her and equip them and empower them with patients who have palliative drains. So we wanted to create a readily accessible tool and an automated system that aligned with patients' goals of care to improve both their quality of life and their clinical outcomes. And we wanted to be mindful while designing this and also minimize the burden placed on healthcare providers. So our solution is called DrainPal. It is a mobile application designed to serve as a centralized hub for patients and their caretakers to access personalized data and troubleshooting guidance related to their chronic palliative drains. So on the left, you can see what this app will look like in a smartphone smartphone interface. Miss M or other patients like her could sign in, create an account, and then once they're into the app, they have a database here, which will prompt them to log in to log their drain status, to keep in track of their appointments, and then log their daily symptoms, which is a key point of DrainPal. So every day they can log into the app, say, oh, my pain's actually getting better with Tylenol. Or they can say, how's your sleep? How's your nausea? These are questions that maybe aren't directly related to the drain itself, but are in a whole picture, very important to patients and their palliative care. Another really important part of this app is that it allows patients to upload images of their drains, including the output, or the actual skin site, which allows physicians and other team members of the patient's care team keep track of the data.
Now, the reason why the integration of these surveys is so powerful is because they take advantage of these regular points of contact between patients and IR that happen, which serve as opportune points of entry for holding palliative care conversations to constantly be reevaluating their health and values. This continuity is crucial for meeting patients' goals of care. Furthermore, the input of patient data into the app is advantageous in that it facilitates provider access to both objective and subjective measures that can be integrated to identify how patients are progressing without necessarily, as mentioned before, burdening providers with excessive communications or alerts.
So speaking of troubleshooting and kind of communications, if Miss M had an issue with her biliary drain, she could go into the app and click on the troubleshooting tab, which would allow her to go through an algorithm that we developed with our IR mentor that prompts a number of questions related to a problem she might have. So for increased output, it would prompt her maybe to call her provider, and it would lead her to the contact information for said advisor. For instance, if she didn't have a problem, and in order to keep her out of the emergency room, the algorithm might determine that her problem at hand is actually not as important or doesn't need an emergent evaluation. So this keeps her from those 10 increased hospital readmissions. Importantly, this data is stored within the app, and patients are allowed to watch over time the progress of their drain. And then patients who might not have access to smartphones, we created an SMS text version of this to allow patients without limited or with limited internet access or perhaps limited smartphone availability to also benefit from the algorithms we developed.
Now, the values conferred by this intervention are many, but to harp on the major points, it arms patients and caretakers with more comprehensive goal-aligned care, facilitates physician efficiency and collaboration, and it decreases costs for the greater healthcare system.
As far as the competitive landscape is concerned, this is not the first mobile health app that has been proposed for patients following procedures. We did a lot of research and found that Surge Care and I Am Here were apps that we actually based DrainPal off of, and we used as really encouraging examples of apps that allow patients to interface with their post-procedure care. However, DrainPal is unique in that it has IR-specific algorithms for IR-placed drains, and we also take advantage of the palliative care symptom assessment scale, which I referenced earlier with monitoring pain, monitoring fatigue and appetite, and things that are very general and allow for holistic patient care.
And while implementation of this app would require further testing and assessment of safety and feasibility, we see great potential in DrainPal's ability to empower patients and enhance healthcare systems with a more integrative model of care. Thank you.
Thank you so much, Team 1. Excellent presentation. All right, we're going to be moving now to Team 2. So I'll be giving share privileges then.
All right, can you see my screen?
Yep.
All right. Hello, everyone. Thank you for joining us today. And today we're going to be talking about Connect IR, which is an application we developed to streamline palliative care. My name is Cameron Fateri.
And I'm Iyer.
And so at the start of this project, we sought to understand what was the state of palliative care in IR today. And through discussion with our mentors and conducting a literature review, we found that IR specialists can perform a number of beneficial procedures for patients within a palliative care context. However, despite the rise in need of palliative care services, there seemed to be a disconnect between patients' need and their understanding of IR. Furthermore, despite being central to the patient referral process, primary care providers and their knowledge of IR within palliative care could also be improved. And so just to reiterate our timeline, after we identified the problem at hand, we brainstormed solutions to find what was the best way we could circumnavigate this issue. And ultimately, we developed an app that connected all three of these parties, patients, PCPs, and IR specialists, in order to best impact palliative care. And so our application, Connect IR, is unique in that it allows both patients and primary care providers the ability to search symptoms, conditions, or procedures and seeing which IR specialists in the area treat those conditions or perform those procedures. Another unique feature of the application is that it has a dual interface. So depending on whether the user is a patient or a provider, the interface is uniquely tailored to that specific user in order to best suit their needs. And another great feature is that the application is very easy to use, and it's very easy for IR specialists to update and advertise what procedures they provide in real time. And we'd really love to demonstrate the functionality of this app. And so now Pui is going to demo the application for us.
Yeah. So I'm going to demonstrate the application from a perspective of a primary care provider. However, there's a unique interface for patients that's tailored to their needs in a more patient-friendly language. So here's the login page, and here's an example of primary care provider. And within the app, as you can see, we have several tabs: conditions, quick procedure references, and a map. Let's take a look at conditions. So here within this tab, physicians can read on various conditions and links for further information from UpToDate. Additionally, these links demonstrate various IR procedures that are indicated for each condition. So for example, let's say I'm a primary care provider and I have a patient who comes in with uterine fibroids. We have uterine fibroembolization. And if we click the link, we can learn more about that. And this gives us like a quick synopsis of what the procedure is, with more further information to our resources such as UpToDate. But let's go back to conditions. Now, let's say I want to find IR providers in my area that specifically do this procedure. So I can click here. It takes us to a map that you can filter by different IR procedures. But since we came straight from the conditions, the uterine fibroid is already selected. And it shows us all the providers that perform this task. But let's say I already know what the condition is, and I'm coming straight from the map. So I can search for condition by text, for example, like uterine fibroids. And that would limit the primary care providers that specifically do uterine fibroid IR procedures. But let's say my patient is in Irvine and I want to look for providers within 50-mile radius. So it only shows providers within that radius. And each provider can have their own profile, which they can link more information to our contact info. And for example, let's say a provider has both academic setting and also a private setting. They can set up different profiles for each and have their oral information there. And they can link to their website as well. But now, let's say you want to educate your patient about a procedure. You can go to a quick procedure reference. Here's a quick information about each IR procedure that you can connect your patients to, and more information and up to date. So what is unique about our app is that it allows the centralization of both the education as well as streamlining the referral process that connects the patients and PCPs and IR specialists in order to best impact palliative care. So in the future, we're looking to develop this into a minimal viable product and launch it for physician and patient use.
Right, and as mentioned, we're looking to develop into a minimal viable product. And we also would like to launch a survey, and we're looking into launching that soon within our home institution amongst family medicine and internal medicine residents in order to gauge the efficacy of the app, as well as what are some areas we can improve in. And then soon after, we're going to launch the application, but we're going to continue to receive feedback in real time from the users. So whether it's PCPs, patients, or IR specialists, we want to gather where are some improvements in the application so that we can best improve patient care as well as the usability and functionality of the application. Lastly, here are our references, and I just wanted to say thank you to all of our mentors who were instrumental in this process, and I also like to thank SIR for providing us this opportunity.
Thank you so much, guys. Great presentation. All right, I think we have 2 minutes before Team 3 presents. So if anyone wants to take a quick stretch break, but yeah, great job so far, guys. Also, David, if you want to start sharing your screen, just so I know that you are able to, and test your audio real quick before you have to present.
Does that look good to you?
Yep, and I can hear you clearly.
Great, thank you.
All right, if you want to start us off, feel free.
Sure, I'll go ahead, thank you. Hi everyone, my name is David Yerk. I'm from team number 3, and I will be talking about MyPal, which is a mobile phone application designed to increase palliative care involvement in stroke management. I'm sure everyone here is already pretty well aware of the basics of stroke care, but I do want to quickly review the timeline of stroke management, starting obviously with the acute phase when a patient is arriving in the emergency department, it's getting their CT scan, and you're deciding whether or not you can push TPA, whether you can be with thrombectomy or something else. Then you have the rest of their hospital stay where the patient might be in the ICU, or you might be determining the source of their stroke or waiting on their disposition. And then finally, you have the chronic, often lifelong portion where a patient is confronting any new disabilities. They might be in rehab, and they'll also be managing any conditions which could have led to their stroke. And the point I kind of want to make with all of this is that there are a ton of people involved in stroke management, and that the team itself changes over time. Obviously, a patient comes to the ED with EMS, they'll see a neurologist, radiology will interpret their scan, IR might do a procedure, then they'll probably be seeing PTOT and speech language path, as well as a number of other physicians throughout the rest of their stay. Then when they get discharged, they might be in a nursing home or rehab, their PCP will get involved, they might have to see other doctors too, they have AFib or carotid stenosis. And then through this whole time, you also have non-clinical people, family, friends, other caregivers, someone like a chaplain who are also very invested in the care of this patient. And you might be thinking, David, where is palliative care in all of this? What is their role? Which is a good question. And it makes a lot of sense that palliative care should be involved in stroke care. Stroke is the second leading cause of chronic disability in the world. In addition to killing 5 million people every year, palliative care has been shown, in fact, to decrease mortality and cost during a stroke patient's stay. They also have been shown to improve stroke patients' quality of life, regardless of the severity of their stroke. So everyone who has a stroke benefits. All that said, though, less than 10% of stroke patients in the United States are actually seen by palliative care. And I should add, those that do are usually people who are facing, unfortunately, end-of-life situations. So the people with most severe strokes, rather than people distributed along the whole spectrum. And that actually kind of makes sense if you kind of consider that not many people really understand what palliative care actually does. You might tell a patient that you're going to have them see palliative care, and they'll think, hey, does that mean I'm going to die? And you even have a lot of clinicians who don't really know what palliative care does, who think that it's inappropriate to consult them unless their patient is in a really severe situation. So the problem we have is actually twofold. We have an education problem where we need to find a way to re-educate patients and providers about palliative care's role. And then secondly, there's a problem of integrating the results of a palliative care consult into the rest of the management of stroke. So combined, those two things led us to develop our smartphone application, which is called MyPal. MyPal improves stroke care by educating users about palliative care's role. It also integrates palliative care conversations with other elements of stroke management, and it empowers the patient and their loved ones to make the best choices for them in their situation. So I want to quickly highlight a few of the features that we have in our app. So first, at the very top, you might notice that there is a chatbot that allows users to track various metrics like mood, symptoms, weakness, or other things that they add themselves. Next, on the left, we have a learning center which contains published literature and documents. We wanted to cover kind of the entire spectrum of health literacy. So this spans things like things that you would find in PubMed, things you would find in UpToDate, and also basic patient testimonials, or like the patient information you would also see on UpToDate. Our app also allows people to track their appointments, their procedures, their med list on the bottom left, the Track My Care, and then it also allows them to add information about their different team members. So that includes both people like doctors and also people like family members and other caregivers who they want to keep connected with. And then finally, we have a message center which allows patients to share information and documents with other users. And the idea here is that they can develop care plans or questions with their palliative care doctor and directly share these with their family members or other providers in their care team, so everyone is kind of up to date on what is going on. And here are a few more screenshots of our app. So on the left, you have a person replying to the chatbot to ask them what their mood is, and then once they replied, they are continuing to be asked about different symptoms. So you can track their strength if they're having strength deficits. You can also add different metrics down at the bottom if you want to track something else. In the center is the knowledge center. So you have a selection of different articles that we put into the app. Patients can add favorites, and you see that they're sorted into different sections. And then finally on the right, we have a patient who's trying to share a document with someone else. So this allows you both to share, educational resources and also, documents that you add yourself, that you write yourself, like a care plan or goals of care. So the impact of our app is threefold, really. For patients, it's really beneficial because they directly benefit from palliative care being involved in their management. It's been shown that palliative care improves quality of life. Defined goals of care also aid a lot in decision making. So once a patient kind of understands what their goal is with their treatments, it's a lot easier to streamline decision making and prioritize one thing over another, if that makes sense. They also have increased access to educational resources, so they can read about different medications or different procedures. And they also have an increased ability to communicate with their entire team at once, including notably their family members, not just all their doctors. For clinicians, it improves collaboration with other providers, namely palliative care, but also the rest of the stroke team. It improves communication with the patient and their family, so hopefully it would reduce the number of questions that they're getting from the patient themselves and also their cousin, their aunt, and their mom. And then finally, it increases awareness in the clinical community about palliative care. which, as I've talked about already, is kind of an underutilized service. And then finally, for family and friends, they're actually in a unique position where stroke places a tremendous burden on both the patient, but also everyone around them. They often become primary caretakers, but they also have to navigate this complex care team that I showed before. So MyPal eases this involvement. They can talk to providers directly, and they can remain connected with their loved one through their palliative care, the sharing of palliative care conversations. And then finally, I want to talk about implementation. So really the major challenge with—
David, I think we're over time.
That's okay.
We'll be able to share your presentation with the judges. Thank you so much for your—
No worries. Thank you.
All right, team 4, you can share your screen now.
Can you see this okay?
Yep, and I can hear you perfectly. So whenever you're ready,
Great.
you can get started.
Okay, great. Hi, everyone. So we're here to present to you PalliNet, our innovative solution to identify undertreated patients for pain management and palliative care. To start off, we'd like to introduce you to Joe. Joe's an everyday 43-year-old guy who's been working in the warehouses of Walmart for 15 years. In high school, Joe was a promising athlete, but he suffered an ACL tear in his knee that, combined with his strenuous job, has led to early onset osteoarthritis. He has insurance through his employer and has been seeing his primary care physician for it, but they haven't been able to treat it. They've tried NSAIDs, PT, and even steroid injections without any meaningful relief and no other options in mind. It's getting to the point where he has to occasionally take time off of work just to rest and recover from his pain. Joe is obviously very upset about this. And not only that, Joe is just one of the 50 million Americans who are living with chronic pain. Between the treatments, the missed time at work, and the lower wages, the cost of this issue is over $600 billion nationwide. Even worse, chronic pain is often undertreated or treated incorrectly, and there are few places that have a holistic, multimodal approach to pain management, which is often what's needed. Joe is dealing with the issue of chronic pain specifically, but this falls under the broader umbrella of palliative care, and there are many, many other patients in similar or more serious situations who can't or don't know how to get in touch with the quality care that they need. Compounding all of this is the opioid epidemic, which has its own costs and challenges and doesn't seem to have an end in sight. Current solutions either minimize opioid prescriptions or without providing any alternatives, or they provide new pain management devices that might offer some relief, but aren't effective when they ignore the big picture of how pain is managed. In short, there's no one addressing the workflow of how patients access pain management and palliative care, which is evidenced by the terrible underuse of palliative care physicians, despite the fact that they're experts in pain management. In our research and interviews with palliative care providers, it was consistently found that they were being contacted too late in the treatment algorithm. Similarly, the field of IR has many palliative procedures that could be leveraged for patients like Joe, but aren't. That's why we came together to come up with our solution, PalliNet. PalliNet is made of 2 different components, a screening tool and a user app that together revolutionize the process of pain management. This process starts with a patient population of people like Joe. When his insurer purchases PalliNet, the screening tool would be implemented into their insurance records to comb that data and use criteria listed here to identify undertreated patients who are dealing with chronic pain. A program would then contact these target patients as well as their respective primary care physician to introduce them to the PalliNet app, which would serve as a hub for patients to interface with our unique care coordination team. This is what the app would look like to Joe, and he could use it to message his providers, track medications, schedule appointments, and manage his visits. Everything he needs for his pain management can be done through this interface. The first visit that every patient would get is a virtual telehealth triage visit with a palliative care provider who would serve as the primary point person for that patient. Using their clinical expertise in pain management and palliation, that physician would determine what new or additional treatments the patient is eligible for and make the corresponding referrals to the rest of our care team. In Joe's case, the palliative care physician found that he could benefit from a radiofrequency genicular nerve ablation and referred him to an IR provider who performed the procedure, but there are many other ways that IR could also contribute to this process that we've listed here. From his ablation, Joe was able to get significant pain relief, get back to many of the activities, and has been able to forego less effective treatments, none of which would have been possible prior to PalliNet. His insurer and employer have also saved money, as Joe no longer misses work and doesn't visit the doctor as often for his pain. Afterwards, Joe was returned to our original patient pool, and when his pain eventually returned 2 years later, he was able to see his IR provider for a repeat procedure through our care coordination process and seamlessly treated once again. This idea of monitoring electronic healthcare data to identify patients who would benefit from specific care is not new. It's been tried for substance abuse disorders, diabetes control, and more. These companies have demonstrated that this model is feasible and have already secured significant funding and attention, but nobody has leveraged this process for palliative care and pain management. This is particularly notable because there is significant evidence in the literature showing that patients have improved outcomes with earlier palliative intervention, and that comprehensive pain management coordination programs lead to improved functional and pain outcomes as well. That's why our goal is to white label PalliNet to insurance companies or self-insured employers so that they can identify patients in pain and help them be happy, healthy, and productive again. Looking at our value proposition, PalliNet stands out through our automated screening program, multimodal care, and ease of use. There are weaknesses such as the technical limits to screening, geographic barriers, and narrow scope of providers offered, but we like to see these as opportunities to grow by leveraging wearable devices and machine learning to more precisely identify patients in need, and opportunities to form partnerships with ride shares and other specialties to expand the limits of the care that we could provide. The biggest threat we realized in our design process was existing companies encroaching into this work. But by being first movers into this space, we would develop infrastructure, connections, and a reputation that would be able to secure substantial sections of the market. In summary, PalliNet is an innovative process that addresses the unmet need to identify and connect patients to care coordination services. And it does so in a manner that is seamless, thorough, efficient, and effective. Here are our references, and thank you for your consideration. Pictured here is our team, and we just want to take a moment to thank Dr. Shah for his mentorship through the process.
Thank you very much, Richard. Great presentation. All right, team 5, if you're ready, you can start sharing your screen.
Great, 1 second, please. Good evening, everyone. Inspired by this year's theme of palliative care, we wanted to emphasize the importance of this field, and thus today our product is CarePal, personalized palliation in your pocket. Presenting today will be myself, Aryaman Gupta, and my colleague Anna Gong. We are team 5, and our mentors are listed at the bottom of the slide. Here we have Miss Lisa. She's a 65-year-old woman with kidney stones and at risk of developing hydronephrosis and organ damage. She becomes hospitalized and a life-saving nephrostomy tube is placed. However, this comes with several issues, including regular monitoring, replacement, radiation exposure, and more. This then leads to a repeat and vicious cycle of hospitalization. Based on extensive interviews with physicians, residents, nurses, and care coordinators with backgrounds in IR, palliative care, anesthesia, oncology, and pain management, we've developed 4 critical design criteria: education, open communication, objective data monitoring, and triage. First, the system should outline the roles of members of the care team, provide personalized reminders about daily health maintenance, and provide education about disease progression, treatment options, and complications. Second, the system should empower patients, loved ones, and at-home care providers to provide a subjective report of the patient's overall health and symptoms, as well as raise any concerns that may not warrant a virtual or in-person visit. Third, the system should be compatible with existing wearable technologies like Apple Watches to facilitate monitoring of patients' vitals and recovery. These can be incorporated into an objective measurement of the patient's pain or symptom severity. Lastly, the system should provide assistance with appointment scheduling for routine follow-up, as well as emergent situations when certain red flag symptoms are subjectively reported or objectively identified. I now like to walk you through an actual mock-up of CarePal. We start at the home login screen. After logging in, we ask who will be recording the set of data, as we not only want the patient to have access, but also any caregivers or loved ones. This allows for multiple perspectives, or if the patient is unable. Let's start with the team and devices. Here we remind the patient about their care team, which includes IR and palliative care. We also list the exact devices the patient has. Below that, you can see notifications and reminders that the care team can push to the patient's phone, such as reminding them to flush or drain their tubes. There's also an option to see specific care instructions that would pull up an additional document with steps and videos. We now move to the daily log, where users can enter the objective pain and symptom data, as well as pull data from the wearables. There's also a free text box for subjective notes. In case patients have red flag symptoms or concerns, they can report this and the app will create individualized suggestions. In this case of a clogged GJ tube, the app provides instructions for flushing the tube, calling Iyer, or visiting the ER. We can also automatically compile reports to send to physicians that will include subjective and objective data, such as pain, days of symptoms logged, and vitals. We compared CarePal to the two most similar products currently in the market, PainScale and MyTube Feeding. PainScale targets patients living with chronic pain and utilizes pain diaries to identify the best treatments for their conditions. MyTube Feeding is an online educational resource provided by Nestle for caregivers, parents, and individuals who are new to tube feeding. These systems do not effectively address all of the needs of palliative patients. Our product, CarePal, incorporates the best components of these existing products into a single, easy to use system that is targeted towards palliative patients. I'd now like to pass it off to my colleague, Anna.
Thank you, Armin. For CarePal at our my apologies. So CarePal provides a lot of value to our market. So there is also patient empowerment, cost savings, and fewer procedures in patient radiation and provider relief. So from the patient empowerment perspective, there can be a 70% reduction in feeding tube, nephrostomy tube, and catheter-related ED visits. So this amounts to about 280,000 per year ED visits, a reduction. And at an estimated cost of $1,000 per ED visit, this is up to $280 million of reduced associated costs. There will also be reduced fewer procedures and patient radiation as a result of reduced unnecessary procedures that will otherwise be addressed by our CarePal app. In addition to all of this, we will also experience provider relief. So our physicians will experience a freeing up of 5 weeks, or about 10% of their time annually, increasing time available for higher RVU procedures. So given that our app would utilize features including secure login, messaging, user profiles, and the ability for patients to input data, it's reasonable to regard this application at least a basic complexity. As of 2021, the average cost for a basic complexity app is estimated to be $60 to $150K. Continuous costs for the app would include features such as continuous data storage for patient information, which would cost approximately $3,000 per terabyte of storage. Following a similar marketing model to patient-physician communication apps such as Doximity, we will also adopt a subscription service that scales with the number of patients in the network. Initial pricing would begin at $100 per patient per year, paid for by either the hospital or the group. So the bottom line is that hospitals and physician groups will be incentivized to adopt our technology because it increases returns in value-based payment models like Medicare and clears physician time for higher RVU procedures. So based on our expected costs and revenue, we expect CarePal to expand to 6 hospital systems by year 2 and break even at that 2-year mark. Initially, we will pursue institutional funding sources to cover prototyping costs and intellectual property fees. Then, as we expand to more users, we will pursue small business grants from the NIH SIR program to cover operational and database costs. So when we think about our implementation timeline, we look to June and August, where we will collaborate with institutional tech developers to create a functioning prototype. Beta testing will take place in September through March of next year. Beginning with a small cohort of patients and physicians, we will actively revise our software during these months. From April 2023 through April 2024, we will launch CarePal institution-wide and collect efficacy data. With the goal of by May 2024, we will seek to enter the market and either seek financial support for app scaling and begin initial contracts with outside partners, or alternatively, we can license CarePal to a medtech company with existing sales channels. So really, in summary, CarePal is our app-based solution that links to mobile devices and wearable devices and serves as a platform for patients and physicians to provide routine updates on current symptomatology and access provider teams on demand. CarePal creates a 70% reduction in long-term tube-related ED visits and associated costs, reduces unnecessary procedures for patients, and frees up 10% of a physician's time yearly. Thank you for your time and attention. And again, we are Team 5.
Thank you very much, Team 5. Great presentation. All right, Team 6, you are on deck. Feel free to share your screen.
Can you see my screen?
Yes, I can. And Kevin, your audio sounds clear, so you can start whenever you're ready.
All right, so my name is Kevin. I'm with Team 6. And today I'll be presenting a long-term solution to palliative evacuation of recurrent effusions. Our device that we created is called a sleeve sheath with coaxial inserted exchangeable drainage catheter, or SCDC for short. Oh. Let's see. So this is our wonderful team. We feel like we presented a really good device here. So our problem is that patients under palliative management of recurrent symptomatic thoracic or abdominal effusions may undergo frequent repeated thoracentesis or paracentesis procedures. This can be a problem because it is disruptive, uncomfortable, and can be costly for the patient. Patients with less than 3 months of expected lifespan may qualify for a Pleurix or similar device to allow for drainage of effusions, but patients may not live much longer than 3 months, while current market solutions often fail in less than 3 months. So combined, there's multiple problems that can happen during these effusions, especially with repeated paracentesis and thoracentesis. Indwelling catheter placements often fail immediately and sometimes don't remain functional within 12 months. Chemical pleurodesis can often fail as well, with a failure rate about 78.2% in 12 months. And so we created our solution. It's called the sleeve sheath with a coaxial inserted exchange drainage catheter, or SCDC. And as you can see here, it has an external sheath. So we made this in our lab, an external sheath with an internal catheter. This catheter could be taken out sterilely. So there's a sterile component right here. And yeah, it works really well. So some key enhancements that we created based on the problems that we observed is that it would require one single invasive procedure. Then the internal catheter could be exchanged and repositioned. The external sleeve would remain in the subcutaneous tissue, and with the catheter, the internal catheter removed, you can also do video endoscopy, separation lysis, biopsy, and other things. There would again be 2 antimicrobial cuffs for infection prevention and help securement. And so we have a video here. This is our device, a little 3D animation. And so as you can see here, this would be the sterile compartment right here. So the inner catheter would be exchangeable through the sterile compartment. The inner catheter has a Luralock system, and it would be enclosed. And again, this inner system is riding with it, going through this external sheath. You can also see here, these are the 2 antimicrobial cuffs, which would both help with infection control and securement to the subcutaneous tissues. And now you can see the outer sheath here with the internal catheter riding within. And now we're kind of zooming in on the end of the internal catheter. And you can see there's 2 holes here. And that was very important because this would allow for early detection of fibrin buildup and early removal of the internal catheter and replacement. And now we're going to go ahead and look at just the sheath by itself. And so this is the sheath by itself. And this would again have sterility, contain sterility. This is as the catheter would be placed to remove pleural fluid. You can see the catheter, the sheath resides along the rib and then travels, the internal catheter travels in to remove the fluid on a defended position. And so we have several materials and designs, different things that we thought about whenever we designed this. So it has a plastic hub with a cap with a sterile interior, as mentioned. We chose polyurethane for the sleeve cannula with an outer diameter of 14 French with a length of 10 centimeters. We also chose polyurethane for the coaxial exchangeable drainage catheter itself. That would be about 12 French, and the length would be 40 to 60 centimeters, and the provider could modify this based on the patient. We wanted to take very special considerations on infections. This is developed as a tunnel device we felt was very important. We have the 2 antimicrobial cuffs, which both, again, really helps with sterility, but also helps with securement. And we kept a sterile environment with an outer cap. And we also wanted to make sure that this device would have an insertion site visualization. It was very important that the insertion site could be visualized. So this device, again, would only require minor modifications to existing commercially available devices. It can be efficiently manufactured, and the initial production cost would be minimally increased compared to existing market solutions. There's a lot of potential stakeholders. Several companies would be interested in this. All these companies have the infrastructure to manufacture this catheter and would all have an interest in keeping or increasing their share of the market. Interventional radiologists would also benefit. This is a new procedure-based intervention, but it would also help to reduce the burden of performing these repeated invasive procedures. The exchange of the inner catheter would be much easier. And so this is our timeline. We've done a very great job in maintaining this timeline. Currently, we're in the Q4 portion. We're going into professional prototyping and looking into different companies. But we've done thus far, really great things with our team. So in conclusion, we feel that this device is expected to outperform existing devices in the market. It would require one single invasive procedure and then allow for repeated drainage. The sleeve would also allow for additional manipulations with the inner catheter removed, such as video endoscopy, debridement of separations, tissue sampling, and other things. And the device would also, the manufacturing requirements of the device is also similar to the existing current devices. And so in conclusion, we really believe that there will be a strong demand for the SCDC device, and it'll be less disruptive, uncomfortable, and costly for the patient. So we want to thank you all very much for allowing us to present. These are our references. Thank you.
Thank you so much, Kevin. Great presentation.
Thank you, sir.
All right, team 7, if you're ready to present, feel free to start sharing your screen once. Kevin, would you be able to stop sharing? All right, team 7, Dr. Chawla.
Good evening, everyone. We present to you DocTalk, an app to assess, educate, treat, and monitor the patient. We would like to present a patient we had at a hospital, a 50-year-old female who had metastatic ovarian carcinoma, for which she was admitted in the palliative care service for symptomatic management. She underwent peritoneal Pleurex catheter placement. After the placement, she was anxious to return home. She insisted on being discharged, even though home durable medical equipment and education on care for her catheter had not been established. She wanted to go home, so we had to unfortunately discharge her against medical advice. But she ended up coming back to the hospital within 2 days, and she had an emergency ED visit because of serosanguinous blood-tinged discharge in the bandage over the Pleurex catheter. If in case she had used the app, she would have known how the vacuum technology of the drain works, how the roller clamp works, the safety of the valve, the management that she can do at home, the usage of the drainage supplies, and also the usage of the app which can record and track the drainage. She would have also known the consequences of how much amount of drainage she needs to do at a time. What happens if in case she drains more than 3000 ml, like example, there'll be decreased oncotic pressure, which causes hypotension. Our app helps to bring the hospital care at home. It helps to assess, educate, treat, and monitor the patient. Problem burden. There is increased need for palliation. More than 12 million adults and 400,000 pediatric patients live with serious illnesses in USA. It is anticipated that about 78 million people will suffer by 2035. Iyer is an important adjunct to palliation of physical symptoms in these patients. There is also communication discrepancies between the physicians and the hospitalized patients. A study stated that 77% of physicians believed that their patients knew their diagnosis, while only 57 of them reported they understood their diagnosis. Coming to affordability, our app helps to provide hospital care at home at a lower cost. Usually the patients go and get treated at the tertiary hospitals and go far away from the hospital to their hometown and then set up remote health. This helps patients to access the care of the interventional team as well as a remote healthcare worker. With COVID, there has been decreased time that the patient gets to spend with the physician. Our app helps the patient to get the needed attention and the care remotely. Stakeholders, the patients and the patient's caretakers are the primary stakeholders because it helps the patients to understand why, what, and how the procedure is done, and the access to the hospital is just a click away. For the healthcare workers, it decreases the burden because they'll be able to provide more efficient care remotely. And for the hospital management, the hospital management is the tertiary stakeholders because with increased patient care and increased communication, there will be better outcome, and the data can also be used for research purposes. This is how the app looks for the patient and the provider. DocTalk is the first multidisciplinary interventional radiology app that is designed to assess, monitor, educate, and treat patients pre-procedurally and post-procedurally by bringing the hospital standard care at home through the app. It helps the patients with remote access to health, reduce the healthcare related costs, educate through the modules, and better communication with the physicians. It will help the physicians in facilitating multidisciplinary team access. Pre-procedurally, the patients gets modules where they understand why they are going through this procedure, what the procedure entails, and what are the steps of the procedure, how this procedure helps them, and what is the immediate post-op care they need to take. This is how it looks for the patient. After the post-procedure, they'll have a checklist of regarding the pain management. For instance, if a patient undergoes kyphoplasty, what is out of 10, how much the patient has pain on that particular day? Did he take the medications that he needed for the day? And what are the lifestyle modifications that he can do? Are there any messages that he has sent to the physicians regarding concerns? And did he receive any replies? And then tracking, he gets to track his progress through after the post-procedurally, and also he gets the instructions. For instance, what are the alarming signs he needs to look for? What deems them to be low and intermediate and high? It is like a module for the patient to see how he's doing. For a provider, the provider, by the patient's checklist through the algorithm, it gets stratified by the risk. If in case it is green, which means it's low risk and it is reassurance and follow-up. If it is yellow, then it is intermediate risk and then a telehealth visit, or which can be through pictures or through the video call, which will be facilitated by the app. And if it is red, that means it is high risk and the patient needs to come and do the in-person visit. It also helps communication between the providers and between themselves, and also provider and the patient. If in case the provider wants to talk to the patient, the messages will be yellow so that the provider understands that's a communication from the patient. If it is blue, then it is the communication from a healthcare provider. Our future directions, we would like to apply for IRB approval and a grant and develop the app, and then we would like to run clinical trials. Thank you to my mentors, Dr. May and Dr. Frimpong, and also to my core team member, Edgar, for helping me in this presentation.
Thank you very much. Great work, Team 7. All right, Team 8, if you're ready to present, feel free to start sharing your screen.
Can you guys see my screen and hear me?
Yes, I can hear you crystal clear and I can see your screen. So whenever you're ready, feel free to start.
Very much. So good evening, everyone. My name is Tana. I'm here on behalf of my team. I'll be presenting to you our efforts on developing Reminder or Remind IR. So we've already heard from many teams the importance of technology and telehealth in palliative care and IR. So Remind IR is a 3-in-1 app for both patients and providers, designed to bridge the communication gap between providers and patients with the purpose to improve access to IR and palliative care. So according to the WHO, there is a lack of awareness and stigma surrounding palliative care. While palliative care is the most effective when considered early in the course of illness, unfortunately, not every patient has access to palliative care. So our team has spent the past few months gathering information to better understand the role and challenges of IR in palliative care. We've identified a few important issues, which are misinformation regarding palliative care, the role of IR in palliative care, miscommunication between patients and providers, limited IR patient education resources, which results in unnecessary hospital visits, as well as loss to follow-ups. And last but not least, everyone's worst enemy, forgetfulness. It's being estimated that patients forget most of the information that is told to them during an encounter. Well, with that being said, there are also other important factors that we found, like the pandemic, the complexity of palliative care, the overwhelming amount of medical terminology that's confusing, the geographic location of the patient versus IR practices, overwhelmed hospital systems, and the issue of noncompliance that all precipitate access to palliative care. According to Farrell et al., the essential components of palliative care is building a good support system around our patients. Our app is designed to help physicians and caregivers stay more involved in the care of patients, while also empowering patients by allowing them to contribute to the treatment plan. So based on our surveys with IR specialists, we found that patient education is one of the most important things to address to improve communication, misinformation, involvement of providers, as well as patient outcomes. So through the iterative process, we've identified the problems and needs, we've surveyed our stakeholders and evaluated the responses and implemented our plan. And then we came up with a mobile phone app, a smartphone app called Reminder. So next I'll be showing the demo of our prototype Reminder and answer a few questions about our goals, who will benefit from using Reminder, as well as who will use Reminder. So Reminder has three main features. First, an education platform. Second, a journaling section for the patients. And third, a calendar and appointment section. So first, let's look at the education platform. This allows patients and caregivers to look up medically accurate information and relevant to the patient's diagnosis, treatment, and procedure. This is an IR patient right here who underwent a recent port placement in their chest. This will help answer common questions and provide information, including pre and post-op instructions, expectations, and device information and care. This will help combat miscommunication, misinformation regarding the instructions or expectations. Next is our journaling section. It allows patients and caregivers to upload photos, document the patient's symptoms and experience through the recovery. This is a sample of a journal entry from our patient who recently had a left arm abscess drain being placed. The journal can also link to the provider's existing EMR, which the provider can read and oversee the patient's progress. This allows the provider to make changes to antibiotics or pain meds and accommodate for changes that occur during the interim. The journal will provide a very accurate history of the patient's experience and symptoms between the follow-ups. We also added a pain journal section where patients can rate their pain at different points during the treatment. This will also help to provide a more reliable history of the patient's pain level, and the provider can also monitor side effects and the dosage of the analgesics. So next here we have a side-by-side comparison of the patient's view of the journal entry versus on the right here is the provider's view on the EMR. So not only the provider can look at the patient's journal entry, they can also create and send notifications and alerts directly to the patient's app. These can be anything from appointment reminders, instructions, like for example here, it's a reminder to the patient to check their abscess drain in the next 24 hours. So in summary, Reminder will both benefit patients and providers by reducing clinic visits, provide reliable information to patients, help prepare for procedures, allow patients to share their logs with physicians, and also help improve access to care. On the provider end, the providers will also benefit from reduced hospital visits to stay more involved in the patient's care. The app also helps physicians answer common questions which are asked, which also helps save time during encounters. Reminder will be customizable, relevant, and easy to navigate to encourage use. Patients who have used the Android or iPhone calendars or note systems will be familiar with the system. Initially, Reminder will be a practice bot and it's pending FDA approval, but down the road, it will be covered by insurance. Before I conclude our presentation, I'd like to share with you a summary of our survey. So based on our survey of IR providers, 70% of the providers whom we surveyed reported that they're interested in trying out Reminder for their practices. This is our timeline. So we are currently in the development of the app and obtaining patents. This is our references. Thank you very much. And pictured here is our team members who made this project possible. And special mention to Dr. Robert Liddell, who is an amazing mentor.
Thank you very much, teammate. Great presentation. Team 9, if you're ready to present, feel free to start sharing your screen.
Sounds
And,
good.
For both presenters, I want to make sure your audio is okay. So if you could.
Oh, it's just me presenting.
Oh, okay. All right. Excellent. Yeah, feel free to take it away.
Sounds good. Thank you. Hello, my name is Amanda Suhako, and I'm part of Team 9, and it's my honor to present our biodesign competition entry about MagnaSeal. So the issue that we decided to talk about was for palliative patients that use long-term indwelling catheters such as percutaneous transhepatic biliary drainage tubes and nephrostomy tubes. Although these tubes are life-saving, they come with a variety of different issues such as 24/7 monitoring, frequent replacements every 8 to 12 weeks, and a variety of different issues that we did I-Core style interviews with our stakeholders, primarily physicians that use these tubes on a day-to-day basis to figure out what issues that they're having with the tubes. So we came out with a variety of different issues, but I want to highlight these 3 that we have. The number 1 being dislodgement of the tubes. When these tubes are dislodged, the patient has to be re-hospitalized and have additional procedures. And for patients, this can lead to traveling far to the hospital, taking time off of work, trying to find childcare. Another issue that we found were malfunctions with the tubes that could lead to further medical complications like cholangitis that could lead to pain for the patient as well as a decreased quality of life. Lastly, sutures, which are the main securement method for these tubes. They're easily tugged on, which causes discomfort for the patient as well as skin irritation and can cause the tube to be dislodged, which is a huge problem. So that led us to the goals of our design for this project. We wanted to decrease the pain and improve the quality of life for these patients. We wanted to decrease the number of dislodgement events and improve on the current methods of securement, such as sutures and stat locks. So first of all, we then wanted to design brainstorming. So we thought it was fun to include some of our pictures that we came up with. We came up with a variety of different drawings, as you can see here. But the final design that we decided on was this, our MagnaSeal. It's a nitinol mesh ring that gets deployed into the subcutaneous tissue. And there's an inner magnetic ring within it, which is why we call it MagnaSeal. And then you can see the catheter going through the ring. And to secure the catheter to the ring, we have this magnetic tape. And we decided to go with this method because it allows for across hospital systems, across departments that uses different diameters of catheters so that they can just wrap the tape around the ring so it's accessible to everyone. This is a very simplified diagram of the deployment mechanism. So you can see in this first diagram on the left that the nitinol mesh ring is already deployed into the subcutaneous tissue. We then see the guiding wire going through the ring, followed by the catheter. And you can first deploy the catheter and see how deep you need it to go, and then mark it before putting on the magnetic tape. So it allows for easy changing, and then you can just push in the catheter deep enough so the magnetic tape locks in with the nitinol ring. So the benefits that we saw for MagnaSeal, we think it's a long-term catheter securement solution. It will decrease the pain and the irritation that patients have, especially with sutures, and increases the quality of life with their ability to shower, their mobility. And then we also know that nitinol and the small magnets that we have are very safe for patients as they're currently being used in other devices. And lastly, we think that it will decrease the dislodgement events and have easy accessibility for interventional radiologists for the frequent flushings and replacements that occur every 8 to 12 weeks. So our next steps, as we're really early on in this process, we have a lot of them, but I think our main one is going to be a cost analysis of production, because we understand that, especially compared to sutures, this is going to be much more expensive. But in conclusion, we think that this is an innovative alternative to current securement methods that could decrease hospitalizations, decrease complications, and increase quality of life for palliative patients with long-term indwelling catheters. I'd like to thank my team members, especially our team captain, Ray, and our physician mentor, Dr. Bailey. Thank you so much for listening.
Thank you so much, Team 9. Great presentation. Team 10, if you're ready, you can feel free to start sharing your screen. All right, whenever you're ready, feel free to start your presentation.
Hello, everyone. My name is Rohan, and I'm joined by Brandon Allen, Monroe McKay, and Joanna Batiste. We're team number 10, and our product is the Luminex. Next slide. So one of the most widely used IR devices, especially in palliative care patients, is the percutaneous nephrostomy, or PCN tube. It has several therapeutic indications, especially for urinary obstructions, for diversion and decompression procedures. Next slide. However, just as we found that PCN tubes are common, so too are their adverse effects. It creates essentially an intraluminal environment that's frequented by urinary flow that allows for a hotbed of bacterial proliferation. And this allows for the generation of crystals, biofilms, and this essentially allows for the ascension of bacteria into the kidneys, and this could develop a pyelonephritis, which is especially detrimental for palliative care patients that are already vulnerable. Now, there are some current prophylactics available for this, including antibiotics and the timely removal of these tubes. However, that poses a logistical and a financial challenge to the palliative care patients who require lifelong tubes. Next slide. Now, another problem with these PCN tubes is that they're expensive, especially when there's recurrent exchanges. We found that each exchange can cost as much up to $3,000, and that can go into the tens of thousands if there are complications associated. So wouldn't it be appropriate if we could establish a solution to this problem where these vulnerable palliative care patients have less frequency of exchanges, less infections, and less financial expenditures, which would save hospital staff time and provider costs? Well, that's what our product, Luminex, seeks to accomplish.
So the solution we came up with is Luminex. This is a novel percutaneous nephrostomy tube that has two unique features. The first is that it has a lumen coated with antimicrobial solution. There's a number of antimicrobes we've considered, and we plan to test these both in vitro and in vivo to determine which solution would be most appropriate. The second feature is a sodium citrate solution coated lumen, and this will help solubilize urine crystals and decrease the frequency of PCN tube exchanges due to obstructive complications. Here's a graphic cartoon showing what our product would look like. You can see in the top right picture, there's biofilms and crystals obstructing the lumen, but with the addition of the antimicrobial and sodium citrate solution, it's disrupting the formation of these biofilms and crystal deposition and preventing complications of PCN tubes.
Now, as far as testing our Luminex device, we first want to do an in vitro study where we're going to consider many different antimicrobial agents, as well as any mixture that we use to see which one is most effective of decreasing bacterial colonization and biofilm formation. From there, we would do another in vitro study where we're going to compare our Luminex device to existing nephrostomy tubes to see if our device is actually effective of decreasing bacterial growth and biofumes from forming. From there, we want to do an in vivo study where we want to do a randomized controlled trial, which involves getting the experience from IR interventional radiologists who are experienced with placing these tubes. And we will do peri-procedural outcomes. Well, we will evaluate peri-procedural outcomes and post-procedural outcomes of our Luminex device. And then if those results are promising, we will move on to our last step of introducing our Luminex device into the market, and we'll be able to evaluate the effectiveness of our device over a longer period of time. Next slide. Now, as far as our discussion of the different antimicrobial agents we want to consider, we would start with our mixture of Bactrim and ciprofloxacin, which is common agents that are used to treat UTIs and pyelonephritis. We also want to include in our study chlorhexidine, which is very effective of preventing central venous catheter bloodstream infections. We also want to consider Gendine, which is a combination of gentian, violet, and chlorhexidine, which is also effective of treating these type of infections. It's actually used in underdeveloped countries, and it's pretty readily available and expensive and has minimal side effects. Now, as far as the crystallization that can form in the nephrostomy tubes, we want to also consider sodium citrate. As you can see in the image in the right-hand corner, it's very effective of dissolving and detaching calcium oxalate renal stones. Next slide.
So here you can see in the top right, the red arrows demonstrate that E. coli growth in vitro within a lumen containing a combination of minocycline, rifampin, and chlorhexidine shows minimal colony formation in the tube lasting through the 3-week mark. While these results seem promising, an important consideration is that an antimicrobial coated lumen could potentially contribute to antibiotic resistance. Another point to consider is the efficacy of culturing for a UTI directly from the catheter. If a patient sustains an infection, an antimicrobial and sodium citrate coated lumen disrupt the growth of bacteria in the PCN tube and result in a false negative culture. Next slide. So in summary, we propose a novel percutaneous nephrostomy tube that may be capable of significantly reducing complications of UTIs and pyelonephritis. The lumen of the tube will be coated with an antimicrobial solution that prevents the growth of bacterial colonies and ascending spread to the kidneys. Potential antimicrobial solutions will be tested in vitro and then in vivo. Additionally, a citrate solution will be applied to the lumen, which will be capable of eluting the formation of urinary oxalate crystals to prevent tube encrustation and obstruction. The ultimate goal of our product is to decrease PCN tube infection and the need for recurrent exchanges in the palliative care population. Next slide. Here's a list of our references, and thank you for joining us this evening.
Thank you very much, Team 10. Great job. Next up, we have Team 11. If you're ready to share your screen, feel free to do so. Excellent. And if you guys could just say something so I know your audio's okay.
Hello.
Yep, perfect. All right, whenever you're ready, you can start.
Everyone, my name is Daniel Lawal. I'll also be hearing from Eva Chow and Alexander Cheng today, and today we'll be presenting TubeSafe. Our team conducted a needs-based assessment through conversations with patients as well as medical providers in pediatric and adult palliative care, hospice, intensive care, and interventional radiology. Over and over, we heard that PEG tube malfunctions and their need for replacement was shown to be a recurrently disruptive issue. This often requires the urgent replacement in the emergency department or through hospital admission. At minimum, this disrupts procedural schedules, and at worst, this can be an overwhelming experience for patients to have to leave the comfort of their homes, be transferred to the hospital, and be rehospitalized. Even when tubes are used according to standard guidelines, they still clog. This problem is heightened by human error in the home by non-healthcare trained individuals.
So per our research, a meta-analysis indicates that up to 35% of PEG tubes will become obstructed in their lifetime. This leads to an array of problems for patients, including but not limited to suboptimal dosing for current medications. This is especially concerning for palliative care patients with pain medication needs. Obstructions also lead to disturbances in nutrition and hydration, and many of these patients don't have alternate oral enteral access. When current post-obstruction interventions, such as clot busters, mechanical plungers, and at-home remedies fail, these patients will then require a tube replacement. This is not only time-consuming, as Danny has mentioned, but costly. Our estimate that overall health, US health system at over $29 million per year. And as 20% of replaced PEG tubes are due to obstructions, this has a significant cost to the healthcare system as well as patients. So with all of this information in mind, going forward in our design process, we wanted to focus our efforts on obstruction prevention. We feel that this type of device would hold more value because current devices on the market, such as those clot busters and mechanical plungers mentioned previously, focus solely on downstream solutions instead of upstream prevention. Our team also found that no other that is currently commercially available focus on the prevention aspect, other than simple pill crushers. So in addition to focusing on prevention, we also wanted our device to be user-friendly for at-home medication administration. We wanted something that was also easy to clean and something that was affordable for these patients. Ultimately, we wanted to keep in mind one of the key pillars of palliative care medicine, which is the relief of unnecessary stress and the optimization of independent living for these patients.
So how do we support this pillar and address these needs? Via an iterative design process, we developed a device that mechanically dissociates crushed drug into a homogeneous solution before injecting it into the PEG line. With prototyping, we added features like a small insert that breaks up the powder, much like what you would find in a protein shaker, as you shake it to ensure disaggregation. Stopcocks so that you close at both sides, as well as a filter to make sure larger chunks don't make it. How? It's a three-step process. First, you crush the pills the same way they do now, whether at home or in an inpatient setting. They unlock the hinge and clasp the device shut after adding water. Stopcocks at both ends ensure the device can be selectively closed, and vigorous shaking ensures a homogeneous solution that can then be displaced with positive pressure into the PEG line. A small filter at the bottom prevents larger chunks from leaking through, which can then be resuspended and broken up again, preventing the suboptimal dosing, which was a key problem we identified. Lastly, the entire device is sterilizable and safe for reuse.
In all, we believe TubeSafe will lead to fewer unnecessary hospitalizations, reduce costs to both patients and hospital systems, and peace of mind for patients and their families. Thank you.
Thank you so much, Team 11. Great work. And finally, we have Team 12.
Hello.
Hi, how's it going?
Can you all hear me?
Yep.
Good.
Feel free to start sharing your screen when you're ready.
Yes. Is that visible?
Yes, it is.
Okay. I just need to start slideshow. All right. Is it all right to go ahead?
Yeah, start whenever you're ready.
Awesome. Hello, everyone. This is Jim and George with Team 12, and we'll be describing our peripheral port technique. So some background. We decided to tackle the problem of chronic pain. Chronic pain is an issue that affects about 20% of Americans, particularly those that are socioeconomically disadvantaged. At least in 2016, we saw that it cost the US about $500 billion, with the expenditure surpassing those of cancer, heart disease, and diabetes combined. About the physiology that's important to our design. Describing chronic pain involves knowing that it involves stimuli, either internal or external, that cause neurotransmitter release that either causes the processing of pain or potentiates it. The conditions causes pain, such as chronic pain from cancer, which may be pushing on nerves, physical injury to the nerve itself, or even chronic diseases such as venous disease that also affects the nerve. And again, these are all affecting the person's processing of pain because of that stimuli that travels through the nerves and causes that sensation. Some current interventions and some of the issues are blocks and injection and stop pain for weeks to months, but have variable rates of success and require repeat injections. The intrathecal pain pump, which is very successful and very effective, but very expensive and very visible on patients. And so it's a very large decision for a patient to accept an intrathecal pain pump. Physical therapy and CBT are great choices to enhance pain therapy, but are limited to external means, in their external means. And then oral and IV medications, again, are effective, but as we know, have serious systemic side effects and serious addictive potential. Boiling that down, some of the problems we want to address in our design are that these current interventions will have some pain associated with treating chronic pain, as well as some scheduling considerations for repeat procedures, some prohibitive costs, and lack of long-term efficacy, as well as addictive potential and how these treatments affect a patient's daily life or quality of life. Solution, what we described as the purple core technique. Effectively, it is a we use for the purposes of a long-acting peripheral nerve block. In the center of the screen is the port design that we were talking about. It looks fairly similar to a normal port, but we also have these holes around the side, which I'll touch on later. So again, it is a peripheral nerve targeted designed to be loaded with liposomal bupivacaine encased in a slow-releasing hydrogel. So what I just described was our medicine cocktail, which is right here. So liposomal bupivacaine, which has been used before and has shown at least about 72 hours of analgesia. Dexamethasone, which is seen in literature to enhance the effects of bupivacaine about twofold. And the hydrogel formulation is so that we can get a slight steady decay of the actual mixture. So that way there's a steady release over time. And so if we look at this timeline above, we can see that liposomal bupivacaine provides relief for about 72 hours to 3 days. If we can enhance it with the dexamethasone, we may be able to double that, to add in the hydrogel proper ratios, we should be able to get it to around 2 weeks. And so the benefits of that are we get this simple medicine administration, fewer side effects from the oral pain medications, no addictive potential, and decreases the or removes the need for opioids, and should be fairly simple removal. Now, a patient would need this if they were maybe at WHO pain ladder step number 2 or 3, which would be when you introduce opioids, and if they were going to use this for about 6 months, because around 6 months is when we start to go past the cost-benefit analysis, and that an intrathecal pain pump might be more effectively what you would be doing with the pump, put it over the pec major, guiding the tube major for stability, and guiding it to the brachial plexus, as seen over here. Once it's in place, we would inject the medication through the base of the pump, and the medication will be released over the actual nerves. So the benefits of this are that the port reduces pain from repeat injections and saves time from frequent visits, especially requested liposomal bupivacaine, which we would be using instead of Exparel, which is a commercially available one. Could save costs by up to 50%, and the port itself should be fairly minimally visible compared to other interventions. And again, no addictive potential. For some cost considerations, placement should be around the same as a normal port, which is about $1,000. Refills based on the cost of liposomal bupivacaine, steroids, and hydrogel materials are going to be about $200. And again, it's going to be bi-weekly, every 2 weeks. And again, we would just use limited amounts at a time. So this should be fairly similar to normal ports and should be cost effective for the first 6 months. Once you get past that point, it becomes more viable to use the intrathecal pain pumps. And if it's significantly shorter, you would use, of course, shorter acting methods. And then, of course, some areas for improvement that we would be focusing on would be testing to ensure duration of analgesia, analgesic pain score data to ensure that patients really are receiving benefit, further minimizing costs of formulating the hydrogel, and enhancing patient education or working with mid-level providers so they can do the refilling of the ports themselves to limit physician visits, so patient schedules are not so heavily affected. And that is our design.
Thank you very much, Team 12. All right, and that wraps it up for all the pitches for the semifinal biodesign competition. I first wanted to thank all the teams for their incredible work. It was very clear that you guys put incredible amounts of effort, and it very much showed. And thank you all to the judges for volunteering to be a part of this process. I'll be in touch shortly about evaluations and things like that. And yeah, and I also wanted to thank actually the committee for helping really set up all the logistics, specifically Selena. She was a legend to send all the emails out to all of y'all in the beginning and earlier months in the fall. So yeah, thank you to everyone for coming out tonight, and I'll be in touch shortly.
Thanks, guys. Have a good one, everybody.